50 or 60 live, but we're getting 100 some downloads.
Okay.
So
Yeah, that's great.
yeah. All right. I think we can probably start if that's all right with you.
Sure.
Okay.
So good morning, everyone. My name is Patrick Samson. I'm a faculty at Cornell, but I'm mainly at the Brooklyn campus. And I've been there since a year ago. I did my training at LIJ for residency, and then I did a fellowship in endourology at University of Washington. So today I'll be talking about surgical stone disease.
All right. Thank you for being here with us, Dr. Samson. We're all excited to hear about this. So one question I think I had for you is that a lot of times as residents, in terms of what to look for in a fellowship, what are some things that you think are important and some things that residents may not understand that they should consider during that process?
Yeah, so I think for me, the most important thing is if you feel that you should, your personalities should match with your fellowship director and the people that you're going to be working with. Because unlike residency, fellowship, it's an apprenticeship. So you're going to be spending a lot of time with your fellowship director. And some fellowships you're working with more than just one attending. So I think that's incredibly important that you get along with them really well. And it's hard, I know it's hard to figure that out on an interview day, and hopefully for my interviews, I usually spend like a day or two with them. So you get a better sense of what type of people they are. And if you can get along with them on a day-to-day basis.
Excellent. Well, we really appreciate you being here, and I'll let you take it away. Thank you so much.
All right. Okay, so here are the objectives of my talk. It's a lot to go through, so I'll try to highlight some points that are covered in core curriculum and the AUE guidelines. Hopefully this will be a good reference for when you guys study for the boards. I'll go over some clinical pearls I've learned in my young career from my many mentors in endourology. So I have no disclosures. Before we go into the nitty-gritty of my talk, I just want to share a few personal opinions. So as a surgeon, you should always look at the images yourself. Before you call your attending about the consult or scrub into a case, you have to have reviewed the scan yourself. Radiologists do make mistakes and they're not the ones operating on the patient. So it's in your best interest to review the images. Number two, I would argue that what makes a great surgeon is not just being technically skilled, but also having the ability to determine the best surgical approach or non-surgical approach. A wise man once told me, you can train a monkey how to operate. So we are not just monkeys, we are thoughtful and caring doctors. We are not technicians. So we'll start with radiographic evaluation. These are the different possible imaging modalities for stones. For the majority of cases, the gold standard is the non-contrast CT scan. The KB X-ray was a prior standard for kidney stones. However, it does not allow you to see radiolucent stones, stones overlying the bony pelvis, such as the distal stones, distal ureteral stones, and stones that may be obscured by overlying bowel gas. You also get very limited information about the collecting system anatomy. The IVP does add some information about anatomy and functionality, but this is only really used in the trauma setting or during a shockwave case when it's difficult to see the stone in the ureter. Moving on to ultrasound. which is a good but not a great modality for imaging stones. It does give us a good idea of the stone burden, the anatomy, and the presence of hydronephrosis. Looking for ureteral jets can give us an idea about obstruction, although this is not foolproof. There's no ionizing radiation with ultrasound, which is why it's the initial study used for pregnancy and pediatric patients. The downsides are that it's operator dependent. It's poor at visualizing ureteral stones. Imaging quality is limited by body habitus, and the sensitivity is limited for smaller stones. One thing to keep in mind is that ultrasound tends to overestimate stone size. So there's a study published about 10 years ago comparing stone size from CT scans and ultrasounds in the same patient that showed that ultrasound overestimates stone size by about 2 millimeters. So this is another reason why you should look at the film yourself. A study out of University of Washington showed that measuring the width of the posterior acoustic shadow is a more reliable measurement than the width of the stone itself. They also found that if the stone does not cast a shadow, this indicates that the stone is likely less than 4 millimeters in diameter. Moving on to non-con CT, which is a gold standard, like I mentioned before. It gives accurate information about stone burden, location, collecting system, and perinephric anatomy, as well as stone density and skin to stone distance, which are all useful for surgical planning. For example, stone density and skin to stone distance has been shown to correlate with treatment outcomes for shockwave lithotripsy. So these parameters can help you set more realistic expectations for the patient. Just remember, skin to stone distance is the average of the 3 measurements between the skin and the stone at 0, 45, and 90 degrees. The major drawback for CT is radiation exposure, especially if you have a patient with recurrent stone episodes. One conventional CT scan delivers 10 to 20 millisieverts of radiation, depending on the machine and depending on the protocol that's used. This is compared to about 0.6 to 1.1 millisieverts for just a plain film KUB X-ray. Low-dose protocols have been developed to try to limit exposure without significantly compromising on sensitivity. Just like conventional CT, there's a range of radiation dosage for low-dose CT, but the consensus for the upper threshold of effective dose seems to be 4 millisieverts. Low-dose CT is actually the preferred modality for patients with BMI of 30 and under. One study showed that in these patients, sensitivity was 95% and specificity was 97% for detecting ureteral stones, while the effective dose was reduced down to 1.6 to 2.1 millisieverts. Low-dose CT, however, is not recommended for patients with BMI above 30. So we'll quickly review acute renal colic. Like I mentioned before, the non-contrast CT scan is a standard modality for imaging for stones. Ideally, the patient should be in the prone position to differentiate UVJ stones from free-floating bladder stones. Ultrasound is the initial imaging modality in pregnancy and pediatrics, like I mentioned before. So recently, there's been a push to limit radiation exposure, which I agree with. A multi-specialty, multi-institutional consensus paper that was published last year stated that CT can be avoided in uncomplicated cases of renal colic in the ER, especially in patients younger than 35 years old. These patients need to have adequate pain relief and no signs of sepsis. Similarly, there's a randomized controlled trial published in the New England Journal of Medicine a few years ago that had 2,700 patients randomized to either point of care ultrasound, radiology ultrasound, or a standard CT. These patients came in with acute renal colic. It showed that there was no difference in high-risk diagnoses, serious adverse events, pain scores, return to ER visits, or hospitalizations. There was a significant reduction in 6-month cumulative radiation exposure in the ultrasound groups. So the caveat to these findings is that they did not look at which patients needed stone surgery or how this impacted surgical management. So a CT is still needed if you are planning on having offering surgery for the patient. So urgent drainage is indicated in the setting of an obstructed ureteral stone and signs of infection. Patients with worsening AKI, an obstructed solitary kidney, bilateral obstructing stones, intractable pain, or PO intolerance would also benefit from urgent drainage. So drainage can be done either by a ureteral stent or a nephrostomy. There's only been one small RCT that compared the two, and it showed comparable outcomes. So it really just depends on the scenario. Is IR available, or is it faster to get the patient to the OR with us for a stent? Is the patient too unstable for general anesthesia for a stent? Or if the patient has a large UPJ stone or a large renal pelvis stone, and it seems like the patient's going to need PCNL in the future, I'm usually able to convince IR to put in a Perc tube. If the patient lacks all of the previously mentioned complicating factors and the stone is less than or equal to 10 millimeters in diameter, the patient is a candidate for observation and trial of passage. So initial management, as you guys know, involves hydration and then a PO challenge to make sure that they're able to hydrate themselves. First-line therapy for pain control is NSAIDs. So there's a meta-analysis published a couple years ago that showed NSAIDs were at least equivalent to Tylenol and opioids in relieving renal colic 30 minutes after being given. NSAIDs also required less rescue analgesia compared to either opioids or Tylenol. And furthermore, there was less nausea and vomiting with NSAIDs. There have been contradicting papers published within the last decade or so on medical expulsive therapy. But it's important to note that the AUA guidelines do recommend its use, especially for distal ureteral stones. The reason why we use Flomax or tamsulosin for stones is because there are alpha-1 receptors within the epithelium of the ureter and with the highest concentration in the distal portion of the ureter. Tamsulosin, which you guys know, is a selective alpha-1 receptor antagonist and has been shown to be helpful in larger ureteral stones and improving stone expulsion rate, shortening time to expulsion, reducing pain while passing a stone, and decreasing the incidence of requiring a subsequent intervention. One thing to keep in mind is the risk of intraoperative floppy iris syndrome, which can be associated with alpha-1 receptor blocker use. Tamsulosin should be avoided in these patients if the patient is planning for or contemplating cataract surgery, or at the very least, you should have a conversation with their ophthalmologist. Patients should be offered surgery if they do not pass the stone after a trial passage of 4 to 6 weeks, or if they're requiring multiple ER visits or significant narcotics in that time frame. Patients should have a follow-up imaging unless the patient can physically prove to you that the stone is passed, either if they took a picture or if they bring in the stone themselves. There's a study out of Mass Gen that showed that 26% of patients who were asymptomatic after a trial passage still had a stone in the ureter on follow-up imaging. And they followed these patients up about 5 to 6 weeks. So they got their imaging 5 weeks later, they still had a stone. Depending on the patient and stone factors, considering doing either an ultrasound or KV or CT to look for a persistent stone and silent obstruction. All right, so we'll talk about selection of management. So this is a diagram I put together based on the AUA guidelines for surgical management of stones. This should just be a guideline, but there are other factors that are not taken into consideration here, like patient comorbidity, patient preference, stone composition, stone density, and skin to stone distance. But not every stone requires surgery. For patients with asymptomatic, non-obstructing calyceal stones, observation with periodic imaging is a reasonable option. Patients should be counseled that there is about a 15 to 30% risk of a symptomatic event in the next few years, and about a 50% risk of progression, although a smaller portion will actually end up having surgery. If a patient does elect for surveillance, I typically recommend repeat imaging within 6 to 12 months, depending on how active their stone disease is. If you guys really want to be precise about being able to predict the risk stratification, there's a prediction tool developed by the Mayo Clinic called the ROX nomogram. It predicts the 5 and 10-year risk for a recurrent symptomatic stone event. In certain situations, asymptomatic stones should be treated, such as those in airline pilots, women who are planning pregnancy, patients with recurrent UTIs, or patients expected to have poor access to medical care. All right, so we'll talk about shockwave lithotripsy. So this is a typical pressure pulse generated by the lithotripter. First, there is a steep positive pressure front, followed by a negative pressure of about 10 megapascals. So repeated shocks cause stress on the stone, causing cracks that grow and eventually cause fragmentation, or comminution is another word for it. There are several described mechanisms for stone comminution that you guys should be aware of, although having a deep understanding is probably not absolutely necessary for the exam. The first mechanism is spalling, which is a result of the shock wave reflecting from the rear of the stone. This generates a large tensile strength inside the stone. Another mechanism is squeezing, which occurs because of the difference between the speed of sound propagation within the stone and that within the surrounding fluid. This difference produces a circumferential force on the stone, causing tensile strength that can actually split the stone. A third mechanism is shear stress, which is generated by transverse waves. As the shock waves pass into the stone, objects that have layers, such as most kidney stones have, are particularly susceptible to shear stress. Superfocusing is the amplification of stresses within the stone because of its geometry. The internal waves, shock waves, converge on regions of high stress. Cavitation refers to the formation and collapse of small bubbles in the surrounding fluid that are created by the negative pressure wave. When the bubbles collapse, they form microfluid jets that hit the stone surface. The last mechanism is dynamic fatigue, which refers to the process of accumulated damage throughout the course of treatment. There are areas of imperfection in the stone that develop more and more stress, causing micro cracks until the stone is eventually fragmented. There are three types of shockwave generators. The first is EHL. EHL involves a spherically expanding shock wave that is generated by an underwater spark discharge. There's an ellipsoid reflector that focuses the wave on the stone target, or the F2. So EHL is very effective at fracturing stones. The disadvantages are that there are large fluctuations in pressure from shock to shock, and also it has a short electrode life. The classic Dornier HM3 lithotripter, which you guys may have heard of, is an example of an EHL machine. The second type of generator is the electromagnetic lithotripter, which produces a magnetic field in either a flat plane or a cylinder to generate the shock wave. These are more controllable, and the shock waves are more reproducible than EHL. They also have a longer generator life than EHL. And because these lithotripters introduce energy into the body over a larger skin area, it causes less pain. But because of the high energy density at the F2 focal point, there's also an increased rate of subcapsular hematoma. And compared to EHL, stone breakage rates are lower, although depending on the study, this doesn't always translate to lower stone free rate. Piezoelectric lithotripters use a large array of small ceramic elements to produce planar shock waves with directly converging shock fronts. These lithotripters have improved focusing accuracy, a longer service life, and because of the lower energy density at the skin entry, there's potential for anesthesia-free surgery or procedure. However, the actual energy delivered to the stone per shockwave is much less than EHL. So every patient that I'm considering doing an ESWL on gets a KUB. Even stones that don't show up on that scout film on the CT sometimes will be visible on a dedicated KUB. So don't rule out shockwave just because you can't see it on that scout film. There's certain techniques that have been shown to improve outcomes for shockwave lithotripsy. Appropriate coupling refers to the coupling medium, which is either gel or oil in between the patient and the treatment head. You want to avoid forming any air pockets in the coupling medium that might weaken the energy being transferred into the patient. Water-soluble lubricants have been shown to be a great coupling agent. So slower shock frequency at either 60 or 90 shocks per minute have been shown to have higher success rates and lower analgesic requirements when compared to 120 shocks a minute in a randomized control trial. Using a ramping up protocol where you start with the lowest power setting and then gradually increase as the treatment progresses. can reduce renal injury and also improve fragmentation. You should image frequently to monitor progress of fragmentation and make sure the stone's still within that focal zone. You don't really need to use the maximum number of shocks, whether it be 2,500 or 3,000, if it looks like the stones are completely, the stone is completely fragmented. Using general anesthesia allows for better control of respirations and has been shown to have higher success rates compared with IV sedation. Routine stenting should not be used in shockwave lithotripsy. There's a meta-analysis that showed no difference in stone-free rates for renal and ureteral stones, whether or not they were stented. Patients who were stented did have a higher incidence of lower urinary tract symptoms. You should consider giving tamsulosin postoperatively and consider percussion, diuresis, and inversion therapy to help patients pass their fragments. Something that I learned at University of Washington was taking a 2-minute pause after the initial 250 shocks. This pause allows for renal vasoconstriction, which was found to protect the kidney from injury in animal studies. I know that in most residencies, you probably have very little exposure to shockwave. So when you graduate, you're already biased against using shockwave for your patients. However, when used in the right setting, in the right patient, shockwave is actually a good treatment modality. So stone size is the greatest predictor for shockwave success. In general, shockwave is a good choice for stones smaller than 10 millimeters. Even in lower pole stones, it's a reasonable option to use shockwave lithotripsy. In a randomized controlled trial between shockwave and ureteroscopy for lower pole stones 10 millimeters or smaller, there was no significant difference in 3-month stone-free rates or need for secondary interventions. They did find that more patients in the shockwave group said that they would choose the same procedure again. So shockwave is still a reasonable option for non-lower pole KLCL stones 10 to 20 millimeters, but the success rates are poor in stones greater than 20 millimeters. The location in the kidney matters. Lower pole stones have lower success rates, as you can imagine. This is probably related to the dependent location of the lower pole, which would hinder the passage of fragments. In a randomized study between shockwave and PCNL, for patients with lower pole stones less than 3 centimeters, stone-free rates were significantly lower for those who had shockwave lithotripsy. In the ureter, shockwave is less effective in the distal ureter when compared with ureteroscopy. Just a reminder, the distal ureter is the segment of the ureter below the sacroiliac joint. Stone density and skin to stone distance has been found to predict success of shockwave as well. As you can see, success rates were significantly lower when stone density was above 900 Hounsfield units, and the skin to stone distance was greater than 9 centimeters. These results were independent of stone size, location, and BMI, at least in this particular study. The AUA guidelines do not recommend shockwave for patients with suspected cystine or uric acid stones. This is an in vitro study done at Indiana University that showed that cystine stones were the most resistant to shockwave fragmentation, followed by brushite stones, then calcium oxalate monohydrate stones. patients on anticoagulation should not undergo shockwave, although there's data to show that if the patient's taking a low-dose aspirin, it's not an absolute contraindication. Pregnancy, having an active UTI and distal ureteral obstruction are other contraindications. Although having a horseshoe kidney is not an absolute contraindication, having the high insertion of the ureter in these patients does lead to lower stone-free rates. So talk about complications. One of the most common complications is renal contusion or hemorrhage. If you scan every patient after shockwave, you'll probably see a hematoma, but these are uncommonly clinically significant. Hematoma rates depend on the type of lithotripsy and the settings used. Steinstrass is another complication. Steinstrass refers to the accumulation of obstructing fragments in the ureter after a shockwave. The risk of this occurring correlates directly with stone burden. So this is something that you really should counsel your patients on, especially if you're treating larger stones. There have been reports that patients may develop high blood pressure, diabetes, and renal function impairment after shockwave, but these haven't really been shown in long-term studies. Moving on to ureteroscopy. Over the past few decades, there's been a steady increase in the share of treatments being done through via ureteroscopy in comparison with the downward trend of shockwave. So we'll start with semi-rigid ureteroscopy. The semi-rigid ureteroscope is generally used for stones below the iliac vessels. It's good to know the caliber of the scopes that you guys have at your institution. But in general, the distal tip of the semi-rigid scopes range from 4.9 to 7.5 French, while the proximal shaft ranges from 8 to 9.5 French. If the ureteral orifice looks a little bit narrow, I usually calibrate the intramural ureter with a 10 French dual lumen catheter to passively dilate it. I found that most of the time, this will give me just enough space to get the semi-rigid scope in. In terms of indications, flexible ureteroscopy is appropriate for stones that are proximal to the iliac vessels, although sometimes you can use a semi-rigid for mid-ureteral stones, depending on the patient's anatomy. Lower pole stones, 10 millimeters or smaller, or non-lower pole stones, 20 millimeters or smaller can be treated with ureteroscopy. Larger stones, you can also treat with ureteroscopy if PCNL is contraindicated. In terms of technique, the use of a safety wire is recommended by the AUA guidelines. Pressurized saline is used to help with visualization, either with a pressure bag or manual pump. And the AUA guidelines do not recommend a routine stenting after every ureteroscopy because obviously because of the urinary symptoms and pain that stents are associated with. Stents should be used in cases with significant ureteral edema, if you're suspicious of an injury of the ureter, if the patient has a stricture or any other anatomic abnormalities that may impede stone clearance, if the patient has a solitary kidney or impaired renal function, or if you're planning a second procedure. So in my young practice, I've probably only done stentless procedures on 5% of ureteroscopies, although I think in general most people, and myself included, are probably overdoing it with stents. So there are a variety of flexible ureteroscopes available in the market. So there are fiber optic scopes that tend to have a narrower profile and better maneuverability. There are digital scopes that have really good optics. There are now a few disposable single-use scopes, and the cost benefit of these scopes really depends on the institution and how often your scopes are needing to be serviced. So get to know the technology at your institution, and if you have multiple types of scopes available, try to learn the characteristics of each one. In general, the distal tip of these scopes range from 5.2 to 8.7 French. The working channel is 3.6 French, which fits instruments up to 3 French. Keep in mind, unlike the semi-rigid ureteroscope, there's only one working channel in which both the irrigation fluid and instruments are passing through. So your ability to irrigate will be affected when when you're using larger instruments. Okay, so let's talk about ureteral access sheaths. The main benefit of access sheaths is the reduction of intrarenal pressure. This does lead to reduced risk of sepsis, which was shown in this large prospective study by Dr. Traxler. He compared outcomes of ureteroscopy with and without the use of ureteral access sheaths. This study also showed that there was no significant improvement in stone-free rates with access sheath usage. And one reason why some urologists may shy away from access sheaths is the risk of ureteral injury, which is actually pretty common. In an earlier study by Dr. Traxler, high-grade injuries were found in 13.3 cases in which access sheaths were used. High-grade injury was defined as one that involved more than just the ureteral mucosa, like the ones in the second and third images here. Luckily, there's a prospective study in Cleveland Clinic that showed that out of 56 patients with high-grade ureteral injuries, only one developed a stricture. So let's talk about laser lithotripsy. The most commonly used laser is the holmium laser. The fibers range from 200 to 1,000 microns in width. And if you're using a flexible ureteroscope, these scopes can accommodate fibers that are 200 to 365 microns. The variability in laser settings depend on the available power from the machine. So commercially available lasers range from 40 to 120 watts. Newer laser machines also have an option of changing the pulse width, which is the length of time which a single pulse is emitted from the laser. So long pulse width is typically used during dusting, which I'll talk about later. Since there's less retropulsion of the stone, this allows you to paint the stone edges without having much movement of the stone itself. There's also less fiber tip degradation or burn back in the long pulse setting. The short pulse mode is typically better for fragmentation, although you'll see more retropulsion of the stone. So you may not want to use short pulse when you're in the ureter. There are typically two main approaches for lasering a stone, first of which is fragmentation and extracting. Typically when you fragment, you want to use a moderate energy setting and low frequency. Short pulse width can also improve efficiency although there's more retropulsion, like I mentioned before. You want to start at the lowest, let's see here. You want to start at the lowest necessary energy setting and rate to preserve the fiber tip and minimize retropulsion. You can always increase the settings depending on how the stone is behaving throughout the case. And since the fragments are larger, when using these settings, you'll need to basket the stones out. And using an Acces sheath is useful in improving your efficiency when going in and out. I typically use this technique, fragmentation, in denser stones like calcium oxalate monohydrate stones. I try my best to extract every single fragment when there is a suspicion for an infectious stone. I really think that basketing is an underrated skill. If you're making 30 to 50 passes in and out of the kidney in a case, those 3 seconds can really add up. Sometimes you may grab a fragment here that looks a little bit too big to fit in the ureter or the sheath. But if you just open up the basket slightly, as you pull down the ureteroscope out of the collecting system, the fragment will rotate lengthwise, and you can often just pull the fragment out without needing to laser it. A lot of times, especially in cases with a lot of stone burden, there'll be a pile of dust here in the renal pelvis. You're not really sure if there's significant fragments. You can just drag your basket when it's half open to see if you're catching anything. So this is the Frogger, which is a fun trick I learned in fellowship, which is basically just using the hand irrigation to flush and flush the pump and then quickly close the basket. When the fragments are smaller, it's more efficient to open the basket halfway so you're not catching too many fragments. And sometimes you might the fragments might hide in the fornix of the calyx, and if you just let the basket bend in that direction, you can often grab the fragments even if you can't see the whole thing. So the other approach to lasering is dusting, which is getting more popular as newer lasers are able to offer much higher pulse rates. The typical settings are low energy and high frequency with a long pulse width. You also want to defocus the fiber tip, which means having the tip just slightly off of the stone to minimize retropulsion. I usually use this technique when the stone is softer, like apatite stones or uric acid stones. If the fragments are too small to basket, or if they're too big for the patients to pass, you can use a technique called popcorning. I'm sure you guys have heard of this or done this. This is done by positioning the fiber tip in the middle of a calyx and keeping the laser activated so that the fragments bounce off of the walls and then come in contact with the laser fiber. This is usually done at a moderate pulse energy and a moderate to high frequency. Fragments that are 1 millimeter or smaller are generally small enough to pass, and you can use something that's already in the collecting system, like your safety wire, as a reference. So there's been an ongoing debate amongst endourologists on whether dusting or fragmentation is more efficacious. This recent multi-center study showed a higher stone-free rate in the basketing group, or the fragmentation basketing group, but that was only shown in the univariate analysis, but not the multivariate analysis. It was also not exactly fair comparison, since the stone size in the dusting group was bigger. despite this, they did find that basketing took almost 40 minutes longer on average, but there's no difference in complication rates or need for a second intervention. Although many residents may feel like ureteroscopy is a junior level case, these cases can go bad pretty quickly if you're not careful or if you don't know what you're doing. I won't go through these in detail since Dr. Gupta already gave an excellent talk on this a few weeks ago. Stents. Okay, so stents are the bane of a stone patient's existence. Most patients who have a stent put in will have some sort of discomfort or either pain or urinary tract symptoms. There have been lots of efforts in trying to figure out how to reduce stent discomfort, but the best way to prevent it is to not place a stent to begin with. After placement of the stent, you want to make sure that it's the appropriate size, since it's been shown in small studies that stents that cross the midline in the bladder cause more urinary symptoms. Belladonna and opium suppositories given at the time of surgery have been shown to improve quality of life scores and decrease pain with urination, although other measures of pain and urinary symptoms were not improved. NSAIDs and opioids can reduce flank pain, but doesn't really address the urinary symptoms. And alpha blockers are meant to reduce the ureteral spasms by decreasing and also decrease voiding pressures in men, which reduces the flank pain that men feel when they urinate with a stent in place. Anticholinergics can help with the irritative voiding symptoms, and phenazopyridine or pyridium can help with the urinary burning. So last topic, PCNL. So PCNL is generally reserved for renal stones larger than 2 centimeters, lower pole stones greater than 1 centimeter, complex stones like Staghorn stones, or stones in patients with complex renal anatomy. Stones that are relatively shockwave resistant, like cystine stones or brushite stones, or stones that that need complete clearance of every little fragment, like struvite stones. These are also good candidates for PCNL. These are contraindications for PCNL, although there is a study out of LIJ that showed that if a patient's on a baby aspirin perioperatively, it was not associated with more significant postoperative bleeding. So in the US, obtaining access for PCNL is done by IR in the majority of cases. There's data that shows that when IR gets access for these cases, there tends to be higher complication rates. Although I don't think it's fair to blame IR for this, since they're not the ones that are treating the stone. So the takeaway message is that even if you're not the one physically putting the needle in, you, the urologist, should be involved in the process of planning for the access. So there's so many ways of getting access. The traditional method is fluoroscopic guided, either bullseye or triangulation. You can use ultrasound. Some people use CT guidance. More recently, people are using endoscopic assistance. And in terms of positioning, patients can be in the prone position, supine, prone split leg, or modified lithotomy. Whatever method or position that you're using, just learn it well, since each method does have its pros and cons. and no matter which method you use, a few principles should be followed. Ideally, you want to get into a posterior calyx, since this aligns, going into posterior calyx aligns with the plane of Brodel and limits potential bleeding. The needle should be parallel to the infundibulum and point towards the UPJ. Ideally, the needle should pass through the papilla or fornix of a calyx, although there was a recent study out of Greece that showed that the risk of bleeding was not increased when getting access through the infundibulum. However, you should not directly puncture into the renal pelvis because of the risk of bleeding. So upper pole access. So upper pole access, obviously there's the risk of pleural injury, but if you have a full Staghorn stone, upper pole access is graded, is more effective for stone clearance. Also, complex lower pole stones, large stones going into the proximal ureter and horseshoe kidneys would benefit from upper pole access. Always review the pre-op CT in 3 views to get a better understanding of the anatomy and plan for the best angle for the needle trajectory. Fluoro-guided access is the most commonly taught method in the US, or at least amongst urologists. Some advantages are that you can visualize your instruments pretty well, and you can visualize the stones as long as they're radiopaque. Main drawbacks are radiation exposure. Often it's difficult to identify the posterior calyx. There's many different ways of doing that with fluoroscopy, but sometimes you could still get tricked. Also, you can't really see the structures around the kidney with fluoro. The main advantage of ultrasound is that there's a reduction in radiation exposure when using ultrasound. The posterior calyx is also easily identified since the posterior calyx is the one that's closest to the probe. It's the one that's at the top of the screen. You can also visualize the structures around the kidney that you may not see on fluoroscopy. So this was a patient with a cluster of stones in the lower pole. Actually, let me pause this. As well as another cluster in the upper pole. And you can see this is the 12th rib right here, overlying the kidney. So I knew I was going to need to puncture the patient twice at least because of the complex anatomy. However, when I slapped the ultrasound probe on, I saw that I would have punctured right through the pleura. You can see the pleura sliding sign right here. And I may have gone through the lung if I wasn't careful. So the disadvantages for ultrasound are that it's not yet widely taught in urology residency or fellowship in the US. It's difficult to visualize wires and dilators, so you do still need to use some fluoro during these cases, and it's difficult to get access if you don't have a dilated system. So I use a combination of retrograde ureteroscopy and ultrasound to get access. So with the patient in the prone split leg position, I have access from below and above. As you can see, I use 2 monitors, one for the cystoscope and ureteroscope from below, and one for the nephroscope up above. Doing it this way does require a capable assistant or co-surgeon. So it's nice to be able to work with the residents on these cases. So I typically put up a sensor wire using rigid cystoscopy from below, then put up a super SIF wire alongside, and then I put a ureteral access sheath in over that super SIF wire. Then the flexible ureteroscope is advanced into the kidney. And then the stone is directly visualized. Then I maneuver the scope to find the posterior calyx. And you can identify that by following the air bubbles. They will go up to the posterior calyx. You can also look for the posterior calyx under ultrasound, which is the one that's close to the probe. Here I'm passing the needle under ultrasound. You can see it under direct vision coming in right there. So I didn't have to use any fluoro for this portion of the case. Glide wires and pass through the needle trocar, and then a basket is used to pull the wire all the way down and outside of the Acces sheath, and then secured with a clamp. The scope is then passed back in so that we can directly visualize advancing the balloon dilator, inflating the balloon, and then passing the Acces sheath. So throughout this whole process, I haven't used any fluoro other than at the beginning of the case when I was passing the ureteral Acces sheath. Stone extraction. So the rigid nephroscope is a standard instrument for PCNL and allows for the use of a variety of lithotripsy devices. So this is from the AUA guidelines. Flexible nephroscopy is recommended in the guidelines since it's been shown to increase stone-free rates and reduce the need for secondary interventions. At the end of the case, the traditional method of drainage is a nephrostomy tube. These tubes can improve clearance of blood from the collecting system, provide a re-entry tract for a second stage procedure, and allows for, if you're planning on it, a postoperative antegrade nephrostogram. However, there is a trend towards tubeless procedures, or quote-unquote tubeless procedures. The AUA guidelines state that in patients undergoing uncomplicated PCNL who are presumed to be stone-free, placement of nephrostomy tube is optional.
Dr. Samson, just want to let you know we got about a minute to finish up before we.
Okay, sure, yeah. So I'll go quickly through the rest of these slides. So yeah, so this is the criteria for a tubeless PCNL. Although the criteria is changing, they don't have to meet all of these for me to do tubeless. Actually, I'm a big fan of tubeless, and it's been shown when you do tubeless, they have shorter hospital stays, shorter convalescence, less pain, less risk of urinary leakage. Although they do have worse quality of life scores because of the stent that you usually have to put in. So this is probably my last slide. Complications of PCNL probably warrants its own 1 hour talk, so I won't go too much into it. So infectious complications are the most common, followed by hemorrhage, pleural injury, visceral injury, and luckily a death is very rare. I just want to show, do I have like a few more seconds?
Yeah, we should start soon. So if this
okay,
that'd be great.
Actually, I just want to mention these two upcoming treatment modalities. I mean, they're still under investigation. Ultrasonic propulsion for this is work being done at University of Washington for stone fragments, residual stone fragments after shockwave or ureteroscopy. Basically, it's a non-invasive way to help patients pass stones. And then burst wave lithotripsy, which they're doing human trials on. And it's basically, here, I'll just show you the video. So this is in a pig bladder. This is just a 30-second clip where you can see so the technology is a little bit different from shockwave. It's got a lower amplitude and higher frequency. It basically just, you can compare it to like dusting a stone from the outside. All right, so that's about it.